was asked to talk about children with severe obesity in special populations, and you can define special populations many different ways. But I think for me, the real purpose of being here today is, well, my purpose, my raison d'etre, to use the little bit of French that I know, is to increase access to obesity treatment globally. And Tom is basically the godfather of adolescent bariatric surgery in the US. And we've learned a ton from Teen Labs and from people like him and people like me thereafter who've been doing bariatric surgery on kids for upwards of 20 years. And there's some young pediatric bariatric surgeons over here. And we don't want folks to have to repeat the mistakes that we did long ago. And so one of the initial mistakes was when the 2004 guidelines came out for bariatric surgery, they picked a BMI of 50, just sort of out of the blue for adolescents. And almost immediately we realized that, there's no reason an adolescent should have to be extra sick in order to get access to care. So borrowing one other thing from Tom, so we learned that we basically need to get access to care to as many people as possible. And we were in an email exchange recently with, I think, with our pediatric surgery, pediatric bariatric surgery sort of listserv where we all ask each other questions and stuff like that. And Tom came up with a phrase that I really wished I'd thought of long ago or thought of myself, which is that he has a non-discrimination policy when it comes to bariatric surgery in children. And I thought to myself, that is exactly what I have. And because I have probably a healthier sense of that than maybe anybody other than Al-Qahtani in Saudi Arabia, I started using the tool of bariatric surgery in lots of types of patients that others wouldn't. And so I get to skip that because Tom talked about that. So before I did that, I had a considerable experience in the garden variety adolescent with obesity. But I actually have not, this is my disclosure, I have not done a bariatric surgery case in 2 years. I gave it all up to be a social media influencer. So please go to my YouTube channel and subscribe, Obesity Explained, or to my website, obesityexplained.com. Shameless plug. But when I was operating, I was doing more than basically anybody in the country each year. And these are sort of my lifetime numbers. And it just, I don't expect Etienne to start in some of these special populations. It's good to get a few hundred cases under your belt first, but that's where I sort of started thinking about who else could benefit, who else was getting denied care for arbitrary reasons that the medical community came up with. So of the 750 cases I did before I hung up my scalpel, you can see that some of them were quite young, 4.5. We'll talk about them in a bit. The rest of this stuff, I mean, this is, I happen to work in DC where there's a high African-American and Hispanic populations, and I feel particularly compelled to help those. We talked about access of care and inequities, and I took care of some of the most people who struggle the most to get care. But some of the things that we're going to talk about are sort of rare. So I have a family. I have a family. I have a brother, a sister, I have parents. There's a family I take care of that is consanguineous, and they have MC4R homozygote children. And I've had the opportunity, pleasure to take care of them and offer them surgery. And I will never forget when the mom came to me to see with her first child who had this MC4R homozygosity. This was in 2011, I want to say. She was from the UAE, and she came over to the US and to see me. And she sat in my office, and we were talking, and her daughter was 4 and had a BMI of, I think, 50 at the time. I can't remember what the percent of the 95th percentile that was, but probably 200 or something. And she looked me straight in the eye and she said, Dr. Nadler, I just have one question for you. And I said, well, what's that? And she said, I just want to know if you are man enough to do surgery on my daughter. And I thought to myself, I'm not sure that brave enough. Sorry, she said brave enough. And I said, to take care of to do surgery on my daughter. And I thought, I'm not sure attacking the manhood of your surgeon right before he might operate on your daughter is the smartest strategy, but it actually worked. And because it actually got me to think about the fact that how desperate this mom was. Now, she didn't know that I actually operated on another kid with the exact same genetic syndrome 2 years previous, after following her for 3 years and watching her BMI go from 50 to 70 over a 3-year period. So I wasn't going to do that again. But the point is that sometimes you're presented cases, patients that are desperate for help. And as a surgeon, I'm much more willing to make an error of commission than one of omission. And so I took a shot, and it actually worked, and it worked fairly well. We've published it. It doesn't always work. I would say the trisomy 21 patients are another group that can do very well. And I've published our experience with them. I've only taken care of one Prader-Willi syndrome patient. I'm not sure I would recommend in that group, but some others have more experience in that than I do. And I think they sometimes can be managed well with not a sleeve gastrectomy or even a gastric bypass, but something called a BPD or biliopancreatic diversion. And then I have a current ROHAD patient who's doing pretty well. I've never taken care of a BBS. So the syndromic or monogenic obesity patients that can't be treated with setmelanotide, I think, are a group of patients that are likely going to need, and you've heard this already before, it's the cancer analogy that was used earlier is the same analogy I use. It's surgery with neoadjuvant chemotherapy or, GLP-1, GIP, glucagon receptor agonism with surgery. You saw Tom's data. You're not going to get 10 years out of any medication. So the death of bariatric surgery is, as was it Shakespeare, is greatly exaggerated. Bariatric surgery is never getting anywhere because you're not going to get a 10-year outcome from meds, and you're not going to get 10 years worth of meds for a cost anywhere the fraction of bariatric surgery. So this other group that actually April was World Autism Awareness Month, so this is a week late, but the other patients that I started taking care of, because lots of people wouldn't, were the children with special healthcare needs. They have a higher incidence of obesity than the average population, and they're often excluded from lifestyle behavior management because they can't comply, or they are they were actually excluded from surgery for a long time because they couldn't understand the postoperative diet. That always was a head scratcher for me, because what do you have to understand other than if you're full, you stop eating, which is basically brainstem function. So we published the first publication on this topic was with my psychologists. That was back in 2019 in Pediatrics. And then Tom's group in Cincinnati, although he had left Cincinnati, I think by the time this got published their results about 5 or 6 months later, showing the same thing, which is children with neurodiversity can, I'm trying to use my best patient first language that I can, do equally as well with surgery as neurotypical cohorts. That was a small study. Last year, we actually published a much bigger study, follow-up, not with the same patients, a subsequent group of patients, and presented this at the AAP in 2023. And it's just an interesting, the reason I'm presenting it is because I find it interesting. And it's one of those things where if you keep an open mind and you do things that maybe others might not think about, sometimes you find results that wouldn't necessarily have been obvious otherwise. So in this group of 493 patients that were all me, I did all the surgeries, they're all at my center. We had 34 that we defined as special healthcare needs, including 16 with autism, 13 with intellectual disability, just low IQ basically, without a diagnosis, and then the 4 an additional trisomy 21 patients and the one Prader-Willi. And basically they looked the same as my typical cohort. And what Tom brought up a really important point, which is the same thing I found when I started my practice in 2005. My BMI is 52. I think you said what yours was, Tom, was like 55 in teen labs, I think. Way too high. That's not adult cohorts, their BMI, mean BMIs are in the 40s, mid 40s. And that's because we weren't getting the referrals. So pediatricians, our community was not sending us patients until they were super sick, instead of sending us patients when they first started to get sick, which would have been better for everybody. So anyway, there are no demographic differences. And when we looked strictly at the special healthcare needs group versus the neurotypical cohort, we didn't really see any differences, although the N were somewhat small, and maybe the group with special healthcare needs may not have done as well in terms of pure weight loss outcomes. But over time, over a year, it sort of evened out. And again, large error bars with small numbers. But this was the interesting finding, which is if you took out our patients on the spectrum, our autism spectrum disorder patients, and separated them from the others in our, that we had defined as intellectual disabilities or the Prader-Willi and the trisomy 21, is the group with on the autism spectrum actually did better than not only the intellectual disability patients, but, and we didn't do the study, and we only had 16 ASD patients, so you can't really, and this is only 13, so the numbers are small, so you can't really necessarily draw any conclusions from this. But these kids actually did better than my typical cohort. And, you know, in retrospect, like after I looked at the data, I was like, I probably should have been able to predict that, because they're more often males, at least diagnosed with ASD now, although the women are catching up now that we're actually screening women for that disease, despite what RFK might say. Another political joke, forget it. You know, so males do tend to do better with bariatric surgery than females. We don't really know why, but they do. And then if you think about a lot of the behaviors in patients with autism spectrum disorder, they're very concrete thinkers. They're very black and white. So if you take away their hunger, either in this case with surgery, but probably the same with pharmacotherapy, they will do exactly what you tell them. You don't have to, you know, there's no like, if you tell them you can't eat candy, they will not eat candy. And I remember one of my patients with autism spectrum disorder actually telling me about how she had to reprimand her grandmother for giving her a piece of candy. And I was like, you do that, you tell grandma she's bad for giving you candy. So in that study, and I don't want to go over my time because I want to make sure we have enough for 7 minutes. I want to make sure people get questions because I'm boring to give a lecture. So with the, you know, so children with special healthcare needs, they basically did well, did fine. And the AAP guidelines actually do say that children with special healthcare needs should not be treated any differently than those without. It's like a sentence, and it's sort of lost in the executive summary, and it's probably not emphasized enough, and they don't give any data to support that because there aren't really that much data. There isn't really that much data out there other than the publications I've shown you in terms of surgery. And I don't know if there are any for meds in that selected population. But the point for me anyway is that, which we've talked about a bunch of times, and it's my sort of one of my taglines, which is obesity is a disease, not a lifestyle choice, and there's something you can do about it. And in this case, it doesn't matter whether you have special needs or you don't. You should have access to care and at least get the opportunity to make that decision with you and your family. So since I have 7 minutes, we'll talk about and I cringed at both the Canadian guidelines, and I cringe every time I read the AAP guidelines because they talk about bariatric surgery cutoff of age 13, which is a nice thing to think about in theory, but in the US, when you put something like that in writing, it means that insurance companies won't pay for surgery under the age of 13. And I lobbied, there's only one, when Stephanie had, I think, the authors up, there was one surgeon on the panel, and it wasn't Tom or I. And before they came out, I was begging him to get that age cutoff removed, but to no avail. So and the reason they use 13 as the cutoff is there's a lack of evidence in children less than 13. So we decided, myself and actually one of our illustrious guests, who I didn't even know was coming, Dr. Janie Pratt, who is an adult bariatric surgeon who is now doing pediatric bariatric surgery at Stanford and is here because she got inducted into the Pediatric Surgery Association today? I don't know. This morning. She and I and a third surgeon from Columbia in New York, or Choney, I guess. We had all been doing bariatric surgery in kids under the age of 13. We just had none of us had ever published it. We talked about it. We always talk about it, but we just never did it. Or published it. So we got together. We looked in the MBSA Equip database, which is the American College of Surgeons and the American Society for Metabolic and Bariatric Surgery got together and put together a registry to track adult bariatric surgery cases in the United States for quality and improvement. I guess that's what they call it that. And what we looked at 5 years. It was basically retrospective because it was whatever we put into the MBSA Equip database. And not all pediatric centers participate in this particular database, and the data that are in there are totally not pediatric specific, so they're borderline useless, but we did the best we could. And then we also looked at our own individual site-specific databases and tried to do the best we could to combine the numbers. But as you can imagine, it wasn't as tight as we might have liked. But what we did find was that there were 47 preteens in the MBSA Equip database. You can see them, on the right there. And the reason that so many of them are Black compared to the overall teen group, which so 18, actually it says teens, but I don't think we went up to 19. I think it was just 18 and under, or 17 and under. But anyway, that's because my center is Janie's population is half Hispanic. Jeff's population is like half Hispanic, and my population is 60% Black. So that's why we had such a high percentage. That's why we had such a low percentage of Caucasians in our preteen group. And just so people know, when we're talking about preteens, and I'm sorry, this is in pounds, but we published it in the US. So that's that's 130, right? 130, 260, yeah, something like that. Anyway, they were big. Patients were heavy, right? The 130 kilos, 120 kilos, whatever they were, BMI 47 as preteens, right? So we're not talking about 11 and 12-year-olds who are any different than the 13 and 14-year-olds or up to the 18-year-olds. They're all, significantly suffering from this disease. And then what was interesting, and probably also we could have figured this out beforehand, but we didn't really think about it, is our preteen group is sicker, right? Because if we're going to do surgery on someone under the age of 12, we really want them to have few other options. So we had a statistically significant higher percentage of patients that were insulin dependent type 2 diabetic. So not just type 2 diabetes, but actually on insulin for it under the age of 13. And then sleep apnea, which was mentioned in an earlier talk, we had a much higher incidence of sleep apnea in our preteens. So in theory, we're self-selecting, selection bias, a sicker cohort. And what we found was, we only did sleeves in these preteens, which I think that's something I would recommend for anyone who's thinking about doing an operation in preteens. The teen group did have some gut bypasses in there. There were none of the complications that are required in that database in our group, as opposed to 0.5% in the teens. No unplanned readmissions, no reoperations, no mortality. And as you can imagine, if you're taking care of preteens, you're on super high alert. And so obviously all the centers put a lot of effort into making sure that nothing bad happened. And that's part of why nothing bad happened. But the point was that it's safe in that age group. And when we did some propensity score matching, the decrease in PMI was comparable between the preteens and the teens, although slightly lower in the preteens. And then when you looked at our individual data, again, the BMI loss isn't as robust or as good as teens in this study. And again, likely because we self-selected a population that one would expect to do less well. But needless to say, we still, 9 BMI points in a year is a reasonable decrease, especially when you're talking about, that's the difference between being on insulin or not being on insulin, or needing a CPAP mask or not needing a CPAP mask. So we're hoping that some of these data might help alleviate some of the concerns about the under 13 age group. Obviously, it'll take more than 47 patients to convince the world, but I think my overall point is that in the right patient, selected appropriately with the right wraparound services, the right support, right team, there really isn't anybody you can't do bariatric surgery on. So going back to my initial family of the MC4 homozygotes, 1 surgery at 4, 2 at 5. The girl at 4 had a re-sleeve at 11, but her BMI from 4 when it was 50, at age 11, her BMI was 40. So that's when I re-sleeved her. And she now is, I haven't talked to them recently, but in the 30s, low 30s or 20, low 30s was the last time I checked. So it's part of, some of the obesity in itself is a complex chronic disease, but in these kids that have syndromes or monogenic obesity, or frankly, some of the children with special healthcare needs, they need a more aggressive approach. And they need that approach in childhood. They need medications in childhood. They need surgery in childhood. They need everybody to get together and come up with the best plan, including their parents and themselves. But I guess my overall point is that, well, I'm not going to talk about that. My overall point is that every patient with obesity deserves access to all care, period. And don't let your paternalistic or what is it, RAM Q 6.3. Don't let people, it's the right thing to do for a million reasons. 1, it's the right thing to do medically. 2, it's the right thing to do because people deserve care, compassionate, comprehensive care. And 3, who are we to say what's appropriate for a family or a child, right? It's a patient-centric is what we're supposed to be doing as professionals now, as providers, whatever we do. And it's the days of us telling you this is what you should have should be long gone. So anyway, with that, Stephanie, my soapbox got bigger than your soapbox on your first talk. My soapbox is now all the way up here. But with that, thank you.
Thank you very much.